The use of AI in healthcare offers some huge benefits, from helping doctors analyze images more effectively to translating and synthesizing documents. But it also comes with any number of potential risks. And this week, we explore the promise and the pitfalls of applying AI in public health. We're joined by Greg Singleton, the Chief AI Officer at the U.S. Department of Health and Human Services, and by economist Dr. David Cutler. He holds a joint appointment at Harvard's Economics Department and the School of Public Health, and at the Kennedy School of Government. We're also joined by former Deputy Assistant to President Joe Biden, Dr. Alondra Nelson, from the Institute for Advanced Study. She's also the former acting director of the White House Office on Science and Technology Policy. I spoke with them as part of a live panel organized by Boston University's School of Public Health. I'm Jennifer Strong, and this is Shift.
Now here on the steering column is a device called Auto Cruise. You simply set the speed you want.
Self-driving robo-taxis are already on the road in 2 U.S. cities.
As the disc rotates, a mirror reflects the light in the way that depends on how the signal was recorded.
This is the 100 terabyte. I present to you Electro, the Moto Man.
Ladies and gentlemen.
I would say that one of my greatest skills is my ability to interact with humans.
This episode, a look at AI in public health. AI already plays an important role in public health, things like diagnosis, drug development, disease surveillance. But the list of reasons to be cautiously optimistic or just plain cautious is also pretty long here. So I'd love to start off. Generative AI is having its moment. How do you see it being used responsibly within public health?
Yeah, I can take a crack at that.
That's Greg Singleton.
There are a number of areas where, at least, frankly, even pretty soon in the near term, we can leverage generative AI to translate documents, to engage increased populations, to provide information to people in an accessible form. There are the opportunities to structure generative AI to digest and provide information to people in forms that they can, understand it, they can get access to it, and provide kind of steering to people so they can engage with the system. They're in maybe a little further out, there are opportunities for some of the AI mechanisms to be, in some cases, like a patient navigator or something that helps somebody get through the healthcare system that we have. So there are a lot of opportunities here. The question, as always, is how do we do this safely and responsibly and cautiously and kind of proceed in a stepwise manner so that we're managing risk?
We recently did a survey on uses of AI, potential uses of AI and barriers to AI use in healthcare.
David Cutler.
The group in healthcare that's most eager to use AI is insurers, payers. They want to use it to streamline some of their things like prior approval processes. So they get a request from a doc to do something and they want to have the AI look at it and decide what to do instead of always having a human look at it. So that's sort of the first use. And they're sort of gung-ho about that, and they're prepared to do that, and they're just, finding the right systems and so on and so forth. On the medical provider end, there's a lot more skittishness. So they would like the AI to be helpful. They're worried about confidentiality. They're worried about making up data. They're worried about the patients and their reaction to it and so on. And so what I think the provider community is sort of looking for some, like, if you will, guidelines about here's how you should do this. Here's the safe things to do. Here's how you should interact with it. I think there will be some leading edge folks who say, hey, great, we're going to go with it. We're going to try and figure out what to do. But I think there are a lot of folks who are, if you will, waiting for either the federal government or someone to come along and say, we believe this is fine and you should come ahead and do this.
If I could jump in, Jennifer.
And that's Alondra Nelson.
I don't know that we know yet that generative AI, if you're talking about large language models and you're talking about the use of multimodal, foundation models, can be used responsibly in healthcare. Actually, I think that's an open empirical question. And I think right now the answer may be no. I think we have seen both in the New England Journal of Medicine and also in JAMA, articles that showed that there was, racial bias in large language models that were used to ask questions by healthcare providers. I mean, I think Greg is right that translation is, I think, probably the best case scenario. But I think even sort of ingesting large documents, we face the challenge of, on the one hand, you're trying to solve the problem of like, what do I do with all of these records? There's, thousands of pages, tens of thousands of pages. But then we've got the challenge of the fabrication and the hallucination, and you actually can't check the distillation to know that it's accurate because you've not been able to read the 20,000 pages or whatever that it's distilled. And so I do think there needs to be a higher duty of care and a higher barrier in healthcare. It's just too important and the stakes are too high. And I think it's also, I raised the issue of professional ethics because particularly if you're thinking about the Hippocratic Oath and you're thinking about physicians, right, do no harm. How do we think about using a tool that we know can be inaccurate? Like, I don't know how as a physician, you obviously are looking for better outcomes. You hope it's going to make improvements for your patients, but you also know that the tools don't always work or work at the level that you would feel comfortable with. And so I do think, again, not providing any answers, but I think that it poses for medical professionals a real ethical quandary, particularly for generative AI. If you're talking about deep learning or neural networks or things that are not intended to generate new things as part of the work that they do, you're talking about radiological imaging, maybe that's a little bit different. But I think generative AI is a struggle for public health, I think.
I've certainly heard plenty of interesting things around using generative within drug discovery within these very narrow types of frameworks. Equally, I live in New York City, and there was a very carefully trained chatbot that was providing advice that's actually against the law. So it's hard for me to imagine, but I wanted to ask if people were working on things or knew of things. Getting back to those guidelines that Dr. Cutler just raised, as is often the case, technology is vastly outpacing the frameworks that might shape its development, legal and ethical. How concerned should the public be about that right now? How concerned are you about that right now?
Well, it's something that we are keeping a close eye on as we look at the evolution of these systems and look at the evolution of practices in the sector. And I think there are a few sides to that question. One is certainly the intentional, legitimate use of AI in delivery of care, in provision of trustworthy services to clients. There's also the possibility for others or outside actors to use generative AI in perhaps harmful ways to cause problems that we are also taking a look at. It's something that right now, with how the tools are being used, again, as people are looking at and focusing on these specific use cases, what are they doing with the AI? What's the risk if it goes right? What's the risk if it goes wrong? But then there's also, how does this compare to the existing system? There are systems that, okay, if it gets a citation wrong or it hallucinates one element of a conversation, but your existing clinician may have a higher error rate than that, or your existing folks may be tired or maybe biased in their own right. We've seen some studies where, since the electrons are essentially free, in chatting with patients, some of these chatbots can be more empathetic and leave the patients with a greater feeling of care engagement than you can from a normal clinician. So we just always have to be comparing to the existing system that we have that is not perfect, not comparing and looking at the existing system as if it's perfect and flawless. So I think the perspective is, do these tools right now, and by the way, these are kind of Gen 0 tools, they're first generation, they will be improved, they're going to be refined, there are a lot of trials going on trying to work on that. If these systems can be used to improve the overall system that we have today, then great, let's go forward with it. But if we're not able to get them to work, if we go through these frameworks, the train system, the group, the CHI group, other folks that are looking at these, and we find that we can't use them comfortably, reliably, in a trustworthy manner, then no, it's not something that we proceed with. But it is something we are paying very close attention to and is part of our everyday discussions with the technology sector, with the medical sector, clinicians, and the public.
In my mind, a very good guide is to follow the money. So whichever way the money goes, think about that. So these things will not, I think, just appear randomly. But wherever the financial use cases will be high on the list, hopefully will have at least some resources to think about clinical and non-clinical use cases where there isn't much money, but where we could still do a lot of good. But I would really look a lot at what kind of incentives get put in place. And I think folks are really still trying to work their way through that. And so helping that, I think, will really help shape where we see the biggest issues and both possibilities and pitfalls with AI.
Can I follow up on that? I mean, I love where Dr. Cutler's going. You know, part of the work that I was doing when I was working as a technology science advisor in the Biden administration was helping to usher through ARPA-H, which is this endeavor. I mean, I think the incentive structure piece is so important. And I think in the context of public health, so not just medicine, but public health, there are lots of things that we want medical technologies to do that might not necessarily, they're effectively market failures, right? They're not going to make money for a company, but they might do a lot of good for a lot of people. And so, you know, I'm glad that David raised that, because I think it's that particular incentive structure for these particular technologies, I think, is something that just still remains to be thought out. I mean, we are living with a major technological transformation driven almost solely by the private sector, right? So, you know, we've got Mariana Mazzucato and others have written about, you know, the investment of the federal government through DARPA and other agencies that got us to GPS, that got us to the iPhone and these sorts of things, with things like generative AI driven almost solely by the commercial sector. And so the incentive structure is vastly different. You know, it's you know, you've got to keep companies in business and keep, you know, startups afloat and these sorts of things, which is a different proposition for something like public health, which has a very different mission. You know, I think there's a kind of misalignment there that it's worth just actively, I mean, it's fine. We've got a lot of market misalignments all through society, but it's just worth, I think, sort of thinking about that specifically. So you asked about policy, you know, sort of keeping up with the technology. I just wanted to raise two other points. One, about this technological transformation being driven by the private sector and or by industry, which is fantastic. You know, innovation at its best is fantastic. But these are also disruptive models. Like in some ways, the whole purpose of many of the models in Silicon Valley is disruption. So if we think of the case of Uber, Jennifer, I also spent a lot of time in New York City, although I'm in Princeton today. You know, it was getting around the taxi medallion system, right? And so the disruption, so when we say that government's too slow, sure, sometimes, but it's also the case that the industries are set up and explicitly to get around regulation, right? So you can't be surprised and say like, oh, you know, they're behind with regulation when the whole sort of raison d'etre of a particular business model or business strategy is disruption. The other thing I would remind people of here as a former government employee that always wants to defend the great work that's going on in Washington is that there has been legislation to help us put guardrails exactly like we're talking about for years in Washington, right? There have been people advocating on the Hill, staffers, legislators, for data privacy for at least 4 years, 5 years. I mean, longer, but like, you know, and then in this more immediate kind of AI conversation. And so it is not that legislators don't actually know what are the kinds of regulations that need to help to keep up with the technology. It's like we don't have the political will to get these things done. There have been very good bills around algorithmic accountability, around data privacy for several years now that would have anticipated and could have been in place well before generative AI kind of emerged in the fall of 2022. So I also want to keep that piece in mind as well.
There's also another element, I think, to not just people going around regulation, but I often say we needed to drive before we decided seatbelts would be a great idea. It's like some of this will be, you know, a little bit of catching up. As everybody is kind of poked at a bit, but I think we should really race forward. AI has the potential to help break down tremendous barriers and help many, many more people gain access to care. Unfortunately, also has the potential to make this process even less fair than it's been. So, Dr. Nelson, specifically with your work, do you have specific suggestions for how we make sure we get that first outcome?
Yeah, I mean, I think that we have got to think about the full technology stack, right? You know, you need to be thinking about these issues around risk and harm. I mean, the way we get to benefits is by mitigating the risks and the harms. And we need to be thinking about them literally at every stage of the design and development of technologies, and to anticipate that they're likely to happen. So, you know, training data, you know, whether or not it's scraped with claims of violating IP or not, I don't know, you know, we'll leave it to other people to litigate that. But data sets come with various kinds of constraints. They've been demonstrated to have biases around race, around gender, and other issues that matter for public health in ways that they might not in other kinds of spaces. Like, the same training data set sort of used for, a recommender algorithm on social media, like maybe we don't care, I don't, but I think when you're dealing with the stakes of public health, we've got to ask those questions. So in the design space, how are we thinking about whether and how we're mitigating bias? Then when you get to the developer space, like are tools being risk assessed? Are we auditing them before they're released to make sure, to the best of our ability, right? You can't foresee everything, but has like sort of good faith due diligence been done before tools sort of enter and systems sort of enter the scene. And then after they're released, particularly when you're talking about more general purpose AI that can have a multiplicity of use cases, then you've got to dig in and sort of be watching to make sure that there's not risk and harm in all those different use cases. I mean, we're talking about with large language models, things that might be used in public health, but also in education and also for leisure time. And the sort of risk calculus for all of those is completely different. But I think we have to move out of a space of, like if you think about the FDA, this is a medical device, we have approved it for all time, for one time, to sort of a much more dynamic and nimble way of thinking about how we're keeping an eye on sort of more dynamic and iterative AI systems.
Yeah. I want to get to questions from the floor. One more quick question, though. I don't know if it's quick. Sorry, Dr. Cutler. Let's talk about jobs. Many of us are here. We're familiar with the example about radiologists. They were predicted to have largely been replaced by the tech. Instead, we dealt with a global shortage. How do we deal with such uncertainty? And what should health systems be doing right now to prepare, given this?
On the clinical side, my guess is, at least for the short term, AI technology will complement and not substitute for clinical workers, because you're going to need the clinical worker for liability reasons, because the doctor knows more things than the computer knows, because the doctor has seen particular circumstances or can recognize particular constraints and so on. The computer and the doctor bring different things to the table. It's not just one is a substitute for the other. So there, I think I'm not worried about mass unemployment of clinical personnel. On the administrative side, there may be more substitution. And I do think that there's some administrative personnel who may be duplicative of things that AI can do. I also think that the administrative side are areas where we need a lot more people to be doing stuff other than just administration. So, for example, we need more outreach to people who are having difficulty coming in, or we need more people to help monitor chronic disease stuff. And a lot of the people who are involved in medical records coding and billing and so on actually have skills that would be quite transferable to where we need people, but we haven't been able to have them stuff. So I think that we're not going to have mass unemployment of people, because the phase-ins are going to be gradual and so on, but that what we could have is a redirection of some of the administrative work that's going into work that's somewhat more patient-facing and hopefully focused more on how do you deal with the patient in need, so that you're not there answering the telephone, which doctor should you talk to, or how should you submit this bill, but you're instead like, okay, these are what the history of the test results are. And so let's figure out clinically what to do, but let's make sure that things are going the way they should, or that the plan that we have in place is working appropriately.
That's something I've been waiting, I think, to see just more broadly in the economy. I think instead of chasing that idea that we've had for 5 years that we've not had the manpower or the people power to go chase, we've been largely cutting. So wouldn't it be nice instead, we're not going to cut our way to greatness. Maybe we can do some more redirection and take advantage of these opportunities. Now, going to the questions from the floor, a lot of people are offering this variation on a similar one. So I'm just going to mash them together and offer this one up. How is an AI system created to be without isms when the creators have their own set of isms? Or, for example, how do we prevent AI bias if the people who teach the AI have biases?
So I will offer perspective, and that is to say, we are at the early phase of these technologies. We have goals in sight, and the goals that are laid out in the executive order: fair, trustworthy, safe artificial intelligence. And what we are working through and what we're developing are the processes to get there. And it will take experimentation, it will take learning, it will take development and communication. I think of it a little bit like baking a cake. You have ingredients, you have your process, and then you have your outcome. And we are working across those dimensions of data reliability, data collection. We're working on model development processes, other things. We're working on the measurement and understanding the outcomes and how they match to our goals. But ultimately, we are working through that process with those goals in mind, as in ways that maybe we aren't with the existing systems, or the existing organizations aren't able to fulfill. So being able to measure things through AI allows us to constantly work to improve, and ultimately with the goal of getting to AI that reflects American values.
Anybody else want to jump in before I go to the next?
I'll just add one thing to what Greg said, which I think is very important. Outside of government, healthcare is a very prove it kind of industry. You don't get to just make a claim. Your claim has to be published, and it has to have been done in a clinical trial, and it has to so on. And so I think that's going to help us with this, because I think clinicians are rightly skeptical about someone just coming in and announcing, oh, I can replace, this task you've been doing just with this program and just trust me. And they're going to want to say, no, show me the evidence for that. And then you're going to have to generate the evidence for that and stuff. So my hope is that as a community, we can hold the ground firm in terms of these are what we expect. We expect it to be accurate, and we expect it not to hallucinate, and we expect it to not discriminate against people. And if we find that, we're going to fix that, or we're going to deny it, or whatever it is. And these are what the expectations are. And I think the federal government has laid some good goals that we can then try and translate into how to make that happen, so that there can kind of be a standard setting, kind of like, a little bit like what the FDA does, which is certify that, yes, when they said this trial did this and found this, that's really what that trial did and found. And then on the weight of the evidence, you can make a determination or not. Sometimes you get it wrong, but at least the goal is to try and always make a scientific determination about what's right and wrong.
I would just double click on both what Greg and David said, and just say again, the challenge that we face with AI and generative AI in particular is that it's dynamic. And so you can't just do it once. The sort of, the FDA model, has often been, you approve the medical device once and off you go. And I think that we need to build, figure out an ecosystem that allows for the sort of empirical science-based checks that David's mentioning throughout that whole stack, throughout that whole life cycle, which is the design, development, and deployment. And so to the question that you synthesized from all the other questions that have been coming in, any designer of any tool is going to bring their own isms, their own sort of perspective to the work. But it is the case that we can do a better job before we release these tools of knowing if that's the case. So we might think about sort of the use of vision-based AI. There were viral videos of people with dark skin trying to use faucets to wash their hands, right? Just merely because they had not been tested. That's just a basic design failure. We should expect much more than that from products. And so I do think that there needs to just be, to David's point, a real transformation, and the responsibility that I think designers, developers, deployers feel is theirs. And also, and thank goodness we've got Greg and others working in this new important role of the chief AI officer, on the government side, putting a check on that.
Another question from the chat. We have, who should be held accountable in cases of errors or adverse outcomes resulting from the use of AI in healthcare, particularly in scenarios involving autonomous decision-making?
In the regular, go ahead, Greg.
No, you go first.
This is your job.
Well, that's why I'm hesitant to say who it should be. I will just observe that there are very few cases in the economy where we absolve folks from liability for things that they participate in. Responsibility tends to lie and stay with designers, developers, organizations, clinicians. It's a shared responsibility chain based on roles, and I don't expect that principle of U.S. law to really change too much there.
Dr. Nelson, you wanted to chime in?
Yeah, the only thing I would add, as someone who can speak more freely than Greg, released from the strictures of government, is that it's hard to know. The challenge that we have faced with increasingly more sophisticated algorithmic systems is that we have no visibility into them. And so you also don't know how things happen, at what stage they happen. When, if something goes wrong on something that's built on top of a foundation model, how do we think about third-party sort of actors in this space? So we've got a lot of, I think, fresh, unanswered questions. still to be answered around liability. We had, similar ones with predictive algorithms, right? Some of the ones that were used more generally came out of meteorology or seismology, sort of like, the large chaotic sort of systems, and became used for things like recidivism prediction, right? And so you could sort of track those a little bit more, but you still we often just don't know what's inside the black box. And I think it makes the liability question a bit more difficult than it does with some other medical technologies.
We have folks who would love to hear the panelists' thoughts on regulation of the data being used to train the models. I was thinking about Colorado, if anyone saw that in the New York Times, on brain data as the state begins to think about what it means.
Just to start off, I want to come back to one of the issues that we came by briefly, which is we want to be trained on what is the truth, not what is the physician's perception of the truth.
Mm-hmm.
Because the physician's perception of the truth has a lot more stuff built into it that may not be the actual truth. And so I really think about doing things on the basis of ground truth. But so for example, predicting who's going to have a cardiac event. I'd rather base it on who actually has a cardiac event, not can I reproduce the physician's perception of it. But I do also want to be cautious, and it comes back to the sort of isms discussion, which is sometimes the ground truth itself can be biased. So for example, there was the example that was written up in article in Science about a company that was trying to reduce readmission rates to the hospital or post-acute spending, sort of people who had an acute event and want to reduce post-acute spending. And so they wrote an algorithm to try and predict who would be a high post-acute spender, and they did not include race in the algorithm. But nonetheless, the algorithm sort of figured out that white patients use more care than Black patients. Therefore, you should clearly intervene if you're interested in saving money and follow-up care, intervene relatively more for white patients than for Black patients. I don't know the actual truth, but I'll give the company the benefit of the doubt, which is say they had no intention of writing an algorithm that would favor white patients over Black patients. But it's still, in that case, the actual honest to the goodness truth was that white patients used more care, not because they needed it, but because that's the way the system was. And so there, I really want to think about the truth as not being I want to save money, but the truth as being I want to improve the health of patients. In which case, then I really will think about the various health problems, assuming I can, of course, measure them, not the diagnosed health problems, and not the physicians telling me what the health problems are, but the actual health of the individual. So I think it's going to be very difficult. But my brain keeps coming to this, what is the honest to goodness truth about the world? Not what is it that someone is reporting to be true.
And how you capture that. I think about this in terms of women as well, or with synthetic data. It's I feel we could have an entire conversation just about that. I have an interesting comment here as well from a woman in South Africa who says, on the one hand, we have challenges with electricity supply in our healthcare facilities, but on the other hand, we're using AI to assist with TB diagnosis in our x-rays. To what extent are African institutions being included in the emerging networks and discussions such as TRAIN?
I don't know. I mean, Greg, you might know, you might be tracking this closer. I think TRAIN's American only, although I imagine many of these health systems are multinational.
Yeah, I think, it is early days for these efforts. There's a lot of work being done, I think, with OECD, with the European Union, with the UN around kind of the AI development. I will say, I know that we also have programs at NIH and others that work to engage diverse institutions, diverse researchers, and help facilitate kind of that engagement with broader communities. So I know we have programs there. I don't know specifically to the direct question on the African-based institutions.
One of my hopes, without answering the specific on those institutions, one of my hopes is that we'll evolve a system for AI like what we have for drugs, particularly essential medicines, which is that we, the world, basically agrees we will sell them in the poorest countries for cost. We will give them away. As long as someone will pay the cost of physically producing the drug and getting it there, we'll just give it away. And we're not going to make money. The world is not going to make money off selling essential drugs in poor countries. And I think we should have the same view about diagnosis, about AI operations, TB testing, all the rest of it in low-income countries, that's not a market that we want to make money in. We just got to cover the cost of getting it there, and then it's going to be free from there on out. And then if you're in a higher income country, fine, you have to pay for it.
All right, so we are basically at time, and we're going to need to wrap up here. Thank you, everybody, for joining us. Thank you to our esteemed panelists. This was my great pleasure to moderate this discussion today. Very much appreciate your time.
This panel was recorded by Boston University's School of Public Health. We heard from Harvard economist Dr. David Cutler, Greg Singleton, the Chief AI Officer of the U.S. Department of Health and Human Services, and from Dr. Alondra Nelson at the Institute for Advanced Study. This episode was produced by me and Emma Silikins and mixed by Garrett Lang, with original music from him and Jacob Gorski. Thanks for listening. I'm Jennifer Strong.
From PRX.